Okay. I think there we go. All right. I think we're live. Instagram live.
I think I'm live.
Awesome. Cool. Well, thank you everyone for tuning in. I'm Dr. Brandon VanderWel. This is Dr. Mimi Tan.
Hi.
Today we are going to be discussing all things weight loss. And people, if they have questions, you're welcome to tune them in. We have a couple of pre-selected questions submitted earlier as well. And yeah, so we'll discuss those. So
great. And feel free to enter questions in whenever.
Yep.
Chat box as we move through.
Yeah, I couldn't get my my Dr. VanderWel Instagram, so that is not online. So it's a little bit one less thing to do, one less thing going on today. As far as that one goes.
Many things juggling. Many things to juggle, I guess.
Indeed. Yeah. Great. Well, today we're discussing all things weight loss. And I think a good place to start from a foundation standpoint is, why is weight loss so challenging? I think this is a good precursor for like understanding why, why do we need some more aggressive tools? Why can't people just like get their act together and, fix their problems if they're struggling with their weight? And our bodies, for me, really, the way I like to explain it to patients is our bodies are really not made for this time. They are made to survive hardships and scarcity. And we're not a perfect by any means in the 21st century, but I mean, the level of abundance and comfort that are the vast majority of people live in this country and in the world, honestly, the world is something that our biology is not prepared for. And so from a math standpoint, if you have a delta, if you have an increase in 100 calories a day, so that means just like you're burning 50 less calories and you're eating 50 more calories. So 100 extra calories a day of a calorie surplus. If you do that every day for a year, you will have gained 10 pounds. Just that alone, of just the difference of like, taking the elevator versus taking the stairs, and, half of an Oreo or something crazy like that. That amount is what constitutes potentially those consistent behaviors and those consistent, like, just using less calories is about 10 pounds a year. And that over 10 years, it's 100 pounds. So it's certainly, this is an overly simplification of the math of obesity, but it does give you a highlight of like, it's just, the margins that you're dealing with here, they don't have to be super big, but if they're consistent enough on the basis, and it's very easy to eat extra calories. I mean, all of us have stood in line. If you stood in line at Costco, you're like, wow, I certainly, all of a sudden I walked out with an extra 3,000 calories worth of food that I'm going to consume in the next few weeks, but I wasn't planning to. And it's just an incredible, it's just something our bodies aren't really used to, or really ready for. So, Dr. Tan, any other questions that we have prepared that you'd like to get into? So,
no, let's see here. Let's see if we have any other questions. But I think your point is absolutely correct. It's incredibly hard to lose weight.
So I think I can, while you're kind of preparing that, I can jumpstart from there, which is, so if you are struggling with your weight, what are the things that you can do? What are the options that you have? There's the nutrition piece. Get your, hey, let's be eating healthy food in small portions to lose weight. Be more active, get some, burn more calories, get a healthier body, which will burn more calories, uses up that extra energy that you have stored as fat. Medications. This is the big one that has like really taken the world by storm in the last year. And that is like particularly medications, the GLP-1 medications like Ozempic or Wegovy or Mounjaro or Zepbound. Those medications are really helpful. And what they do is they make people less hungry. They just make you think about food less. It's not just that you're less hungry. It's just that the gravity of food just seems to be less powerful. When you're thinking about, like that attraction to food, it just really seems to be able to affect how that attention and that your brain has towards food. And you can all of a sudden, where you could never walk past the candy drawer, when you're hungry, you always went and got something. Now you're just like, you walk past something, that could care less. You can really avoid it much more easily. It makes you feel more full as well. And so you actually literally can't eat as much food because your stomach kind of does fill up with food much more easily because it's not emptying out very quickly. And then we move on to the endoscopic procedures, like the endoscopic sleeve gastroplasty, where you have a suturing device and it goes down. And this is where you take your stomach, which is this big bag. And Dr. Tan, you and I both spend a good portion of our weeks looking at people's stomachs. And the stomach is just a big bag that's hungry. It wants to eat a lot of food. It wants to really help, get a lot of stuff. And you just eat as much food as you can anytime it gets a chance. So making that thing smaller by suturing it closed down more is very helpful. It's a very helpful tool to with those things. So VJ says hi. So thank you, VJ. So a quick comment from Enrico, recently joined. Feel the hardest transition from the therapeutic practice is simply decreasing calories. Is there a way to eat more strategically in order to prolong the satiation? Good question. So Enrico, great question. Thank you for that comment. Let's unpack a couple of the dimensions, I think, first on our experience and our relationship with food. I kind of describe it as generally three things. There is appetite, like how hungry you are. There's satiation, like how satisfied you are. And there's restriction, and that's a physical stretching. So appetite comes from several hormones that probably relate to making you feel hungry and have a desire for food. That's the proactive go get food. I think of satiation as more of a term of like, hey, I am content, I am good. This satiation, you get this sort of like this dopamine hit generally when you're satisfied. And it's kind of this survival instinct of, oh yeah, I'm good. We are happy. We are going to survive. This is a step towards making it through the winter. And then there's the restriction piece, and that's a physical stretching of stretch receptors. So they're like spring-looking cellular nerves actually in all of your muscles have them. And as they stretch out, they tell your body, ow, we're stretching, we need to stop. And that's a physical restriction. As you're from decreasing calories, as I think is what you're referring to, and how do you stay satisfied? Truthfully, like the very best, the easiest tool to help you with that is having a smaller stomach. That intestinal stomach cell surface lining of your stomach really tells your body like, hey, we want more food, and there's a certain threshold that we need to meet to be satisfied and send you satiety signals and hormones. When you have a smaller stomach, either endoscopic sleeve or laparoscopic sleeve wise, there's not as many cells there, and it's much easier to be satisfied with a much smaller amount. With that, the dietary pieces definitely contribute a lot to this. I think a good comparison is if you ate 2 cups of broccoli versus if you ate 2 cups of butter versus if you ate 2 cups of maybe let's say a chicken thigh, right? The experience, even though that's the same volume for each of those, the experience that your body would feel is extremely different from each one of those. And the reason is that because there's chemical reaction, the molecules of those foods are interacting with the cellular columnar mucosa and creating and giving you hormonal signals from each of those things as it's interacting with those. So having more satiety, the easiest way to feel more satiety with the decreased calories is protein. So, and the reason for that is, sorry, Dr. Tan, I'm kind of taking over here.
Okay.
With protein, what's going to happen with that is that protein is actually a very complex molecule, and it's going to take a lot of energy for your body to break down. So that takes time, number one, and it takes energy to actually do it. And you're going to get less calories just by eating more protein as opposed to other sources of calories because it's complicated for your body to break it down. And then it slowly is going through your bloodstream, and slowly it takes time for it to be broken down. So it makes you feel satisfied for longer. And your body has to do more work on it. And it has certain signals. There's actually certain spots in your cellular columnar mucosa in your intestines that interact with the protein that sends signals to your body. All right, that was kind of long-winded. Sorry, Enrico. Dr. Tan, thoughts, comments?
Yeah, I mean, I won't add too much more to that. I think, like protein is probably, if we're talking about macros in terms of what types of food are going to fill you up the most, that you get the biggest bang for your buck from a satiety standpoint, that is going to be protein. And that's part of why we push protein a lot when it comes to weight loss. It's partially because it is advantageous in a lot of ways. It takes more calories per gram to burn a gram of protein, essentially. So in some ways, you're boosting your metabolism if you're looking at it in a certain way. It'll also sit in your stomach for longer, so you do feel a little bit fuller for longer as well. So that helps. And then I think the other bigger picture, and like when we are helping folks lose weight, when you're losing weight rapidly, which, caloric restriction is still a very important part of that. But as you're losing weight, we want to make sure that you're maintaining your muscle mass. And in order to do that, you do have to maintain your protein intake. If you're not taking enough protein, you're losing muscle more rapidly. Your metabolism goes down. And so there's that advantage as well. So protein, and then also shout out to fiber as well. We talk a lot about protein, but fiber is another nice, bulking agent in a lot of ways, and that can also help you feel full. And it's a good carbohydrate as far as carbohydrates go.
Helps everything work better.
It helps a lot of other things too.
Yeah.
And no one eats enough fiber, so that's been my newest soapbox.
Yes. Oh, there can be so many.
Yeah. Well, I don't think we have any questions from online. This was kind of a spontaneous live for us. But I think a good topic that we could dive into that a lot of people are interested in is GLP-1s, maybe, and
how to get the most out of them and what to do if they're not working
that
well
might be a good one. And just kind of going, because it's been a while since we've done one of these. And I've spent a lot of time, I feel like, reflecting on this with some of my patients too, is the pros and cons of GLP-1s versus maybe some of the other medications that we have on market, and then pros and cons of other tools that we have as well. Because I think at this point, more and more people are starting these GLP-1s, and maybe their reality is a little divorced from the expectations. And so maybe kind of talking through some of that might be fun. I don't know.
Yeah.
So yeah,
let's hit that one first. I think expectation wise of what people do expect that we see and what people generally experience, I think it's honestly kind of frustrating, I would say. Because I was very optimistic when we started our program a number of years ago that, hey, we do aggressive weight loss. We have the most expertise. Our dietitians are extremely good at, really dialing things in. They're very attentive. We are good at weight loss in general. I think we're going to get even better weight loss with our medical weight loss program than other people get in their program. And unfortunately, we're going through our data now, and it's really about the same as everyone else experiences. Semaglutide's getting in the 9-10% total body weight loss range, and tirzepatide's in the 14 to 15%, which is kind of what everyone that I've seen that has real world data experiences. I wish that, we're just really not seeing the data that we saw in the STEP trial and the SURMOUNT trial for semaglutide and for tirzepatide, real life. So there are certainly people that are doing really well, and there are the people that are crushing it. It's very interesting to see that in people's consciousness, everyone thinks that with medication, they're going to be like the people they've seen that crush it. And with surgery, it seems like everyone thinks they're going to be the people that don't respond. Whereas it's exactly the opposite. The surgery people, by and large, they're 3 times better. They lose 3 times as much weight as the semaglutide people do, and twice as much as the tirzepatide people do. And but people have the inverse kind of thought process towards those things. But
yeah. Well, I think you brought up a couple of really interesting things that I want to expand on, that I've actually adjusted in terms of how I talk to my patients. One is real world data with the GLP-1s versus some of the ideal data that we have out there. And so, I used to quote folks with the GLP-1s of 15 to 20% ranges, which is what we would get from some of these studies that we have. But, in a lot of ways, those studies are divorced from reality. People are in very vigorous environments trying to, and maybe higher doses than what we often achieve in real life. And there are a lot of things that prevent folks from kind of getting those same results in reality. So it's interesting to see that, what I'm now quoting to folks is somewhere between that 10 to 15% range with a lot of these injections, because I think that's maybe more realistic. I think a lot of people go into starting these injections with very, very high hopes and high expectations. And certainly some folks do amazing. Like
even doctors,
knows,
pharmacists, like I have people all the time just be like, oh yeah, obesity is cured now, right? With Ozempic.
Yeah. And it's because everyone likes that example of the person who lost 100 pounds, and that happens.
Yeah.
But certainly averages are a little bit lower than that.
That's the understatement of the day.
But I mean, that's true for everything. That's also true for bariatric surgery, right? Like I have to reset expectations for folks sometimes. But I think the other thing that, to kind of help folks like understand it a little bit better, I think it's like, what is the efficacy? And the efficacy is beyond just average numbers, but like, how likely are you going to have a good result from this tool? And like, if we're thinking about like oral medications, I tell people like the oral medications are kind of crappy for this reason. Like it's super hit or miss in terms of who responds to those oral medications. Like it's kind of just, it's, I would say it's almost 50-50, if not even less than that, in terms of who actually responds to some of those meds. Super helpful for some, really just not anything for other folks. The GLP-1s are great because most people do respond to them, but maybe not the optimal response that we would hope for. And then, like bariatric surgery, it is very reliable in that sense, is that I feel like you are going to lose weight with it. It's not totally foolproof, but people lose weight.
Quick comment, Enrico, we'll get to your question here in a sec. So, he just submitted a question a little bit ago.
Oh yeah, well,
I want to make sure. Yeah, let's do it. Okay, Enrico, appreciate the detailed answers. You're welcome. Curious what levels of weight loss you guys focus on. Specifically asking about, are we talking about obesity, or is this advice also applicable to someone who is not overweight looking to lose weight? Great question, Enrico. Yeah, I would say obesity, we kind of, the way I approach this, Dr. Tan, you can kind of give your perspective now. In my evolution of my practice with obesity, I try to actually approach it a little bit like we approach cancer. And that sounds a little melodramatic, but not all cancers are the same. And not all stages of cancer are the same. And so each of them requires their own little different treatment and approach. The people that have like very early stage cancer, or like stage 0, stage /0 or 1A cancers, like our approach to those is a little bit different than people that have like stage 4 cancers. Similarly with obesity, if you are in the overweight category, not quite obese, or maybe even a little bit below, and you're just trying to lose some weight, their approach is generally different. And I'd really try to say, hey, let's really focus in on the nutrition piece. I do find that maybe a little bit of medication sometimes for some of these people is very helpful. It is, I would say everyone's medical weight loss program is really busy. So if you're in the lower BMI category standpoint, it can be hard to kind of get in sometimes because there's so many people that are trying to get in. But I think it's a really helpful tool. Medication can be a really helpful tool. Even just like a little microdosing of GLP-1s I've seen people do. I don't do a ton of it myself because I don't take care of a ton of like super low, lower weight people. But that has been helpful. There's other little medications like you were talking about, Dr. Tan, like phentermine can be a little bit helpful. It also has a little bit of like helpful stuff for ADD people. So it's about kind of working with your doctor. But generally, the lion's share when you're in the lower BMI categories is the nutrition exercise piece, and really getting those things dialed in as well as you can. Particularly if your BMI is below 25 and you're looking to lose a little bit of extra weight, generally it's a macro question of your macros, I find. So really kind of try to go to more of a protein heavy situation, and really watching your calories and being consistent with those you just have to be consistent with it for a long time, because your delta there is just not very much. I will say though that like there's quite a few people in like the celebrity sphere that have, BMI 30 or below that look at get endoscopic sleeves and do a little bit of GLP-1 medication. Like that's a thing out there for sure. I've had several patients that I've done endoscopic sleeves on for people that started with a BMI below 30. And I really made them like, hey, we got to make sure that we're pursuing everything else here. Like I don't want to like, I really want to make sure this is the right thing for you. And they're like, yeah, I'm working out. I have a trainer. I have my food plan, diet all in. I'm really, really struggling to really get past this point. They've done the endoscopic sleeve and they've crushed it and been so happy with their result. So I think that it's a worthy of a conversation sometimes, from a procedure standpoint for some people, from a medication standpoint. It's just, there's a lot of different things. So, but for the heavier BMI things, then we start talking about more aggressive stuff. So, Dr. Tan, what's your approach?
I would say it totally depends on what you are hoping to achieve with weight loss, right? To some degree, it matters how much weight loss you're hoping to achieve, and then what are your other goals? Like, what are some of your other health goals that you're trying to get to? That can vary for a lot of folks. It can be metabolic improvement. If you have diabetes and you only want to lose 10 pounds, you might, like a gastric bypass might still be a really good option for you, or a sleeve might be a really good option for you just from a diabetic, like metabolic health improvement standpoint. If your goals are more like mechanical, like arthritis, or you are hoping to get a knee replacement, then again, that changes our weight loss goals as well. So it varies. And I feel like it's a pretty personalized discussion. And then depending on what you're hoping to achieve, then we can kind of pick what works best or what's most sensible, I think, or effective for you. But yeah, it's one of those things. It depends. And I'll say, like, I don't really pay attention to like BMI categories. Like, BMI is a helpful number to have sometimes, but I typically don't worry too much about like the obesity versus overweight versus regular weight categories too much. Except when insurance requires me to.
Exactly. Because that gives you, the BMIs give you a nice, you need some way of categorizing things, for population studies, for, things like that. But BMI is it's a very crude tool. So, because everyone's pretty different, which is I think it's fascinating, like the different ways that people, the people's bodies are made, the way that they hold, like, their extra fat, like, though it's very interesting how wide of a spectrum there is in that. And we see it acutely, for a lot of different ways that people hold their weight, and a lot of ways that people, get their lives better from these things. So I had a great conversation with one of my patients this morning, and she was a year out from surgery, and she has lost 101 pounds, and she's just like, so happy, crushing it, doing such a great job. And, she was like, man, I feel so much better from the moment that I wake up in the morning, and I am, more active, doing more stuff. And she's like, it's interesting how, like, she's like, I'm getting more like accolades and promotions and stuff like that at work. Like, the perception of people of that I'm much more successful and capable person has significantly increased since I've lost weight, which is sad to say, but it's generally true, and very commonly experienced by people that struggle with their weight, is that they're generally viewed as not as competent or not as capable. So it's crazy to see how that has changed as I've lost all this weight. But the coolest thing about, I think, the journey of weight loss is that it really changes the story that you tell about yourself, and the person that you realize who you are and what you can do really seems to really change for the better. And that part is so cool to see, how people, really start believing in themselves and what they can do. So, yeah. And that's what, because obesity it's so hard. Once you're there, it's so hard to get out. And it can be, I had just talked to a guy just now, just recently, and we were discussing, different options and stuff like that. And he's just like, I don't want to live the rest of my life like this. I don't, I'm limited. I can't go, go the places that I want to go from a travel standpoint, from a hiking standpoint. I can't do the activities I want to do. And this is, I don't want to be like this for the rest of my life. And I've tried everything, and I've had some success, but then I've lost it. And it's, it's a journey. It's a really hard journey. But what is awesome is that we have fantastic tools in the era of bariatric surgery plus a little bit of medication. We are seeing such positive things. Like, it's very cool. So.
Yeah, it's cool. I mean, it's still shocking to me how often I hear from patients, like, that it is so refreshing to have a medical provider who listens to the struggle that they have been going through and tell them that it's not their fault, right? And it's like the first time that they're hearing it ever, because they've heard their whole life, no, it's you're doing something wrong.
Yeah.
You should just be
You
eating
suck.
less. No,
Yeah.
you're lying to me about how much you're eating, which is who does like no one's doing that. Like, you know, all these different things and just being heard and realizing that there are some tools out there is kind of amazing for some folks
Yeah.
here. So it's cool.
Yeah. It's a wild journey. It really is. So, speaking of which, the question you kind of started with at the beginning was medication. What are the best ways? What are the best way to use the medication? What are the kind of the troubleshoots most commonly have to overcome? And what do you do when the medication isn't enough?
Yeah. So I like to let's see here. How do I start here? So these medications, I think they're being advertised a lot of times as like the cure to obesity. You know, it's the magic pill. It's the cure-all for all things. And of course, there's a little asterisk with it, I think, in that, yes, you will probably lose a little bit of weight if you just take these medications. You know, you'll probably just be less hungry. You'll eat a little less. You'll lose a little bit of weight there. But there is an optimal way to lose weight with these medications. And one of my concerns with these medications is that people are not getting enough counseling and enough support in order to, again, be using these medications as optimally as possible. No medications that we have on market right now are like metabolism boosters or like fat burners. I tell all my patients that, like, if you see anything advertised with those things, it's not scientifically backed. We just don't have, like, we're working on metabolism boosters, but they don't currently exist on market in a way that's super effective.
We had Fen-Phen.
Fen-Phen was effective, but had its
hell
own
of a
problems.
drug. Yeah.
But you know, the injections, what they help facilitate is they help facilitate diet changes and they help facilitate lifestyle changes. And so if no one's guiding you along the way with those, then it's difficult for you to, one, lose as much weight as you can, and then also actually keep that weight off. And then the added question of like potentially getting off of these medications. I would say, I don't have any data, but like I would say it's probably harder for you to get off the medications as well while
It's
maintaining your weight. Yeah.
So I quote people 25 to 30% can get off and maintain their weight loss, but
is that kind of from your experience or
that what? It's both from experience. And I think there's the paper, I think the step, you know, they're one of the, I can't remember exactly, but
yeah,
it was like 60% of people had discontinued the drug at a year, and half of those had been able to maintain their weight loss, which puts it at, you know, 30%.
I think, there's at least one study that's like 80% of people gain weight back, right? Like it's just it's so hard to come off of them.
I don't have a ton of people with normal stomachs, you know, that are in my practice, you know, that do medical weight loss. But I do, you know, I try to talk to as many people as I can that I know are out there that are on it. And it's only been a handful that I've met that have been able to successfully come off it.
Yeah. So I you know, we spend a lot of time talking about optimization of these meds. For me, probably the biggest thing is preventing muscle loss. I feel like there's been a lot more knowledge about this. There's been a lot more articles written about like the sarcopenia, which is a very scary word for muscle loss. But we do worry about muscle loss really anytime you lose weight rapidly. It's not the injection itself that's causing muscle loss, it's the rapid weight loss without proper nutrition and proper exercise. And so we spend a lot of time talking about nutrition, optimizing protein, and then we do spend some time, unfortunately, talking about exercise, which is everyone's least favorite topic, least favorite thing to start working on, but it is important, very important.
Yeah.
So I'm finding, folks, and I've started asking, like, what's your strength? Like, do you feel like you're still as strong as you were when we started? And it is upsetting to hear sometimes that folks are feeling less strong, and that's concerning.
Very concerning.
Yeah.
Yeah, I agree with that one. The question of like, how's your energy level doing? Do you feel like you have more energy, and are you stronger? Are you more capable? Because if you're not those things and you've lost weight, like, I don't think we're helping.
We're not helping you.
Yeah. We're just, that's a dangerous place to be.
Well, I would say, like, we're probably helping you in some ways, like, but we're maybe harming you in a lot of other ways too.
I mean, those are bad indicators. If you're losing weight and not feeling more capable, it's, your overall frailty is going up probably. So, when some people aren't losing enough weight, which is, a lot of people, we see them every day, I'm sure, like in our practice, which is people that did the medications and they're like, yeah, I lost some weight and then I kind of stalled out, and then, or I stopped it for whatever reason and I started gaining the weight back, or I have gained all the weight back. What do you usually, what's generally your approach for those people?
So my first step is to go back to basics. What we all tend to do whenever we start a new diet, start a medication, for folks right after surgery, is everyone's really excited, right? You're motivated, you're going to do everything to a T. So you're perfect with tracking, you're measuring all your portions, all of these different things that we typically talk about. And then over time, it's very natural for most folks that they get into a routine and then they stop doing some of those things. And then it's also very natural for some of those behaviors to slide ever so slightly, like just, maybe every week you start eating a little bit more of this or that, or you start grazing a little bit more. And I call it behavioral shift, like your behavior just kind of slowly shifts. And so if you find that you're struggling, the first thing to do is go back to basics, start tracking again, start seeing how much protein you're eating, measure out your portions, start tracking how much fluid you're drinking, and just do that for 2 weeks and see what is actually going on. And sometimes it is because if you're, you're stalled out, it is truly just because at how much you're eating right now. Like, weight loss gets harder as you lose more weight. That's just the reality. Your metabolism goes lower. You require fewer calories. And so at some point you are going to plateau. So that might just be the case, in which case then we have to talk about maybe re-strategizing, doing some other things. But oftentimes I find if it's been a minute since we last talked, it's because of some of that shift in behavior. And we just have to kind of reset things a little bit from that standpoint. So no one likes tracking, or I would say most people don't like tracking. I do have some folks who really love their tracking.
A couple rare birds.
Yeah.
I hate tracking personally.
But it is helpful. It's a good tool.
It's very helpful. Yeah. Yep. It's a very good tool to at least experience for a while. So
what about you? What are do you have any?
Yeah, I think it's the same thing. Get back to the basics. Okay. Like let's revisit what's our nutrition choices that we're making. What is the portion sizes that we're doing? What are our macros? Are we tracking those? And then I ask like, well, if you could identify one or two things that if we could just fix that, you would make improvements. And these are frustrating things for you that you feel like you want to improve on, but you're kind of stuck in. So I like to ask that question because sometimes that's like, well, there's this at nighttime, I always snack, or, at this time when I'm busy with this and I'm leaving, I always stop by the gas station. And I get this, and it's just like, well, that's really, I feel like that really throws me off. So we try to identify some major low hanging fruit to work on. And then I always look at dosing wise. Are we at a dose? Are your appetite good? Are you having side effects? Are they managed? Do we need to change the dose? Do we need to dial in? Do we need to see the nutritionist? But then, if they have a long ways to go, if they're still, a long ways from where their goal is, I say, nobody wants surgery. Like nobody wants to have a procedure to fix their, to get to where they need to be. But sometimes we do need that. Like our bodies are just really hard to survive really hard to thrive in the 21st century the way they are. They are great at thriving in very austere conditions, but, you know, thankfully for indoor plumbing and electricity and, you know, climate controlled and cars that practically drive themselves now, like our lives are just pretty different. So sometimes we need to consider those things and think about like if that's the right time, especially if someone has a lot of comorbidities, like if they have bad sleep apnea, if they have or if they have high blood pressure, if they have diabetes, like you have all these things in your hand, and the answer to the answer to this problem is surgery. Like, you know, it's at some point, especially if you have a bunch of comorbidities, or if honestly for guys too, because guys, you know, they don't survive obesity very well. And I think we need to be more especially aggressive. It's like, you know, we should probably seriously consider being really aggressive right here. And I like to put it in a time frame wise, like if we consider surgery and we're doing surgery in 6 weeks, say, or, you know, 8 weeks, where you are in 6 months from now, like here's how much progress we've made in 6 months. Where we will be in another 6 months if we do surgery, you know, in 2 months is pretty incredible. Like, and that's nothing's a guarantee, but the reliability of that is very high.
Yeah. I mean, and to jump off that, I think it's so important for people to know, to have the right expectations with each of these tools, because if you don't have the right expectations, you're going to end up feeling like a failure if you don't, like, oftentimes your expectations are maybe more than what some of these tools can provide for you. Yeah. And then you get frustrated when you aren't reaching your own personal goals. But you just don't have a tool that's strong enough. It's not your fault. It's honestly just the tools themselves have limits in terms of how much weight loss that you can achieve. So, you know, very frequently I have patients come to me who wanting to lose 150 pounds with one of these injections because that's what they're seeing on TV, right? Or they've heard of the person who's lost 150 pounds with these injections.
Their coworkers doing it and they've lost, yeah.
Yeah, the reality is like that is the top 1% of people. And, you know, all of us think that we're in the top 1% of people, but that's just not how math works. And so, you know, I don't think there's anything wrong in like trying these tools, but then when you hit a plateau, realizing, okay, there are limits to each of these tools. And obesity is, you know, excess weight, obesity, it's a chronic disease. It's challenging. And like cancer, like any other chronic disease, sometimes it takes more than just one tool for us to really get a good whack at it, you know? Yeah. And that's the reality of the disease. So,
yeah, I think the important question to ask ourselves, I think, especially people that take care of patients, right, that struggle with any number of health conditions and obesity being upstream from many of them, is if like our job as doctors is to help the most amount of people with this disease have the most amount of success in treating it and being, you know, and really putting it behind them, we have to know at least what the absolute most successful thing is. And then all the other options that are maybe not quite as successful, but are still viable options. You know, it's kind of like, you know, first, second, third line treatments for different diseases that we have. Yeah. And really first line, I believe strongly now, looking at our data, looking at the data that's out there, first line therapy for obesity, first line, especially for people with diabetes, they should at least know that surgery is the best tool for that problem. Yeah. And then really, if you want to know what the absolute best course of action is, surgery plus a little bit of GLP-1 medication is a fantastic combo. And those combos really, really help people get the most success. If you want to talk about the most amount of success you can have, that is how you get it, is you do a surgery, you do a little bit of medication with it. And then you can talk about, okay, well, that you should at least know that that's the best one that there is. And if you should at least be able to, you know, you're willingly opting out for saying, you know, I know that it is, but that just sounds a little spicy for me. Like that sounds a little bit intense. Is there something a little bit less intense? And then you kind of talk about all the options from there. So like an endoscopic sleeve, which is a non-surgical procedure, no incisions, you know, very safe. Nothing's removed from your body. And then you're like, well, it's still a procedure. I'm still scared of anesthesia, all these other things. I know it's safe. I know it's not necessarily reasonable that I think I'm going to die. which most people don't really think that. They're just like, it just seems like a big decision to make, is to do a procedure.
Yeah.
But the next piece of that is like, well, okay, the medications, like that's a much more approachable thing for people. But, you know, I think we just need to understand what the expectations and the results are generally on average.
Yeah. I mean, I think this is where I think the cancer analogy is a big eye opener. Like I'll use that analogy sometimes, and it is a big eye opener for a lot of folks, because there is so much stigma when it comes to weight that we still really, like, I know everyone keeps saying these days that, yeah, obesity is a disease, but it's still really hard for people to frame it truly as a chronic disease. And like the comparison I like to make is that if you are someone who has, say, diabetes plus obesity, and the diabetes is related to the obesity, right now, the current practice is we give medications to it. We give medications until you have all these complications down the road, and then maybe we'll refer you for bariatric surgery.
Yeah.
And what we actually know is that, one, there's time sensitivity when it comes to getting you to bariatric surgery, and potentially how much that affects your improvement in your diabetes. But if you get someone in early enough, within the first few years of your diagnosis, we actually have a really good chance of reversing, like completely curing your diabetes.
Yeah.
Right now, with medications alone, there is no cure for diabetes. You are just going to continue to get worse and worse and worse, potentially needing more and more medications. It's just, that's kind of what the deal is. But if you get a bypass, say, the 10-year data is you have a 25% remission rate, meaning you're on 0 medications after that. And if we make that comparison to cancer, like if there is a cancer that there's a 25% cure rate of that cancer with a surgery, there's no one in the world who is going to say, no, I don't want that surgery. You know, and it's a low risk surgery, right? Like,
when the alternative is essentially just suppressive therapy with chemotherapy.
Exactly. Like, you
not curative, suppressive. Yeah.
And insulin's awful. Like, all these medications that we have for diabetes, for the most part, are really challenging. So it's like, kind of like, would you rather do chemo for the rest of your life, or would you maybe want to give it a whack and try this surgery? If you frame it that way, like, no one is going to be like, oh, that's crazy that you're doing surgery so early. Like, no one's going to say that. And so, man, we have a lot of challenges still. The fact that we don't see it that way, it's challenging. So,
but it's an opportunity for messaging.
It is. Anyways, I don't even know how we got here. I don't know why I started talking about that. I just get riled up talking about diabetes, and
the diabetes one is particularly frustrating. Yeah. When you have, and it's our own field. It's our own it's our own, profession of medicine. We have our family practice residents that come and visit with us and learn about obesity. And like, I always ask them, like, how much obesity did you learn in medical school? Because most of them are in their first or second year residency. So they're pretty fresh off, school. It's like none. There's no obesity in medical school. Yeah. It's crazy.
Yeah. So it's
like, essentially you're graduating as a doctor without any scientific understanding of the most prevalent disease of our time.
But that's also why we have so many patients come to us saying all their lives, all they've heard is diet and exercise.
Yeah.
Right? Because that's all we've been taught.
So, but it is hard. Obesity is a tough disease to treat. So I understand why a lot of the PCPs don't want to approach it. Number one, they don't have a lot of good tools. Like, if you don't have surgery as your ultimate, like, there's a lot of people doing medical weight loss practices that are like, they hit some home runs. There's some good people. There's some stuff going in there, but there's a lot of strikeouts in a medical weight loss practice. Whereas in a bariatric surgery practice, man, it is just like win after win after win. It really is. It's that the default is really good. The majority of people have really good results as a rule. There's some things you have to navigate for some people, but man, the regret rate on bariatric surgery is like, less than 1%. So,
yeah. I mean, and it's not to dunk on PCPs. PCPs these days, they're the.
Oh yeah, no, it's just it's so
They're
hard. It's
It's
so hard.
just hard. Like
It's hard. There's so many layers to obesity. It's a disease of biology and behavior, and you have to unpack all of it. And it comes down to, and it all centers around even just like their personal identity and their mindset. And like, gosh, that takes so much time to unpack and to work on. Like it is, I don't blame them whatsoever. Like it's a very challenging disease.
It's challenging. And I mean, that's why, like, if you think about just like the resources like just the people we need to run a clinic like ours, it's great. Like we have, we need dietitians, we need coordinators, we need like all these people who are just here specifically to help us, insurance coordinators, like all these.
We got our psych people that we have on that we have the relationships with.
It takes a village to deal with something like this, and so it's tough.
Yeah. Cool. All right, Dr. Sam.
Fun.
Well, that was good. Yeah. No, it's good to getting back into it. We're gonna have more scheduled visits coming up. And in the future, I think one of our goals is to actually start bringing some patients on, and you can, people that are out there can ask patients what it's like, what's the experience like, after weight loss surgery. And we'll interview them and kind of get them to share what their experience has been like and what they think is helpful and what things are, what things aren't. And just kind of see their stories. And it's because that's what this is all about. It's all about the patients, it's all about seeing them succeed and overcome such a barrier, such a burden literally in their life. So
yeah, we'll have some, hopefully we'll do a little bit better advertising about these. Well, I don't know, whatever.
Yeah. One of these days I'll get my act together and get on TikTok at the same time. So
yeah, and if folks have suggestions for topics or questions that they want addressed, always feel free to send them to us and comment on our YouTube videos, or send us messages on whatever social media platform we're on.
Yep.
All right. Okay. Cool.
Very cool. All right, everybody. Have a great day, and thank you for tuning in.
Friday.
Yep. Bye.